and welcome. Yes, thank you for recording, Laura. So I'd like to welcome you all and thank you for coming. Especially thank you to Dr. Kara Rudolph for joining us today. Dr. Rudolph is an assistant professor of epidemiology at Columbia. She is a graduate of our program, and her advisor was Dr. Tom Glass, and her dissertation was entitled Mental Health in Context, Effect, Heterogeneity, and Mechanism in the Relationship Between Neighborhood Disadvantage and Adolescent Depression and Anxiety. She also worked closely with Dr. Liz Stewart in a master's in biostats and as a postdoc, and she continues to collaborate with her today. She also did a postdoc at the University of California at Berkeley. Hang on, my notes just disappeared for some reason. Okay. And did that with Dr. Mark Vanderland and Dr. Jennifer Ahern. And her current work focuses on developing methods for transportability and mediation, applications in the context of adolescent drug use across populations. And more generally, her epidemiologic research informs efforts to optimize resources for effective policies and programs. I've had the privilege of listening to her talk at SCR conferences, and I must warn the audience to buckle up and please pay attention because she's one of the sharpest minds in the game. So it's our great delight to welcome Dr. Rudolph back to Hopkins, and thank you so much for delivering the seminar.
Well, thank you a ton, Derek. That was a very sweet introduction. I'm excited to be here. I was saying that this is even though it's virtual, this is my first formal, like coming back to Hopkins Epi, which I'm excited about. Okay, so I'm gonna try, actually, I should have tried this before. I don't know, actually. Maybe if this is fine for you guys, if you can see this fine, maybe I'll just do this. Unless if I do full.
Looks fine to me. Yeah.
Okay.
I think it's good.
Okay, great. Okay, so I am going to talk about trying to learn two strategies for reducing opioid use disorder relapse. And while I talk, if you have questions, if you have comments, please interrupt me. And I usually cannot see comments, so if you don't mind like unmuting yourself, that would be super. Okay.
Sounds good, thank you.
Okay, great.
We can also keep an eye on the chat too.
Oh, okay.
So
perfect. Yeah, so just please interrupt, of course. Okay, so as a little bit of background, probably a lot of us know this already, but opioid-related overdose continues to be a national health emergency. And actually it got better for a little period of time, which you can see on this graph, and then it got worse during COVID. There are 3 FDA approved medications for OUD, which have been shown to be effective in randomized trials. And so these are called injection naltrexone, buprenorphine, and methadone. But then,
I'm sorry, I don't think the slides are moving. Do you mean to be moving your slides?
There should be new words appearing. Do you see new words
appearing?
Is
it just me?
No, I don't see it. Now it's moved to
now it's on the background slide. Motivation slide.
Yep.
Okay, so
it was just on the title slide for the first couple
minutes. Okay, so I'm just gonna do the non-full screen and hope that works better.
Okay, perfect.
Okay, so these are 3 effective medications, but there's like kind of an asterisk with effectiveness, as those of you who work in the field probably know, which is that even if you take these medications, the risk of overlaps is still for me anyway, as an outsider coming into it, surprisingly high, which you're going to see in some of the data that I show. And so that is really motivating, like, given that there are these treatments, but given that, they don't work amazingly well, it's really motivating some trying to optimize how treatment is delivered. And so there are 2 strategies that we're going to try. And so the first is optimally matching patients to the particular medication. And so this is kind of a cornerstone of precision medicine research, and it's been applied in other areas of health research, but hasn't really been applied, well, it hasn't been applied at all for opioid use disorder. And I feel like it hasn't been applied much for substance use disorder generally, although I would love to hear if others have examples of it. Okay, so we used a comparative effectiveness trial called XBOT to try and look at this, which is nice because it's randomized. And so in this trial, injection naltrexone was compared to buprenorphine that you would take orally. And this trial found that once it was initiated, injection naltrexone performed equivalently to buprenorphine in terms of preventing OUD relapse. But I want to point out that this is an average, right? So like, it doesn't mean that these two medications would be expected to perform equivalently for any particular person who walked in for treatment. And so then a question is, how could we examine effect heterogeneity across people? So if you think about, papers that you look at, like what do people typically do? So typically people do this and they'll include interactions, right, in a regression model. And then they'll test whether like a single interaction term is significant, like one at a time. And there are some problems with that. And so I'm including, like Tyler Vanderweel wrote a couple years ago this article that I'm including down there, which I think he does a really good job explaining like, well, what's wrong with this strategy that, basically we all do. And one thing that's wrong with it, of course, is that people are multidimensional. So it's not like, it's not like you can say like, oh, there's important effect heterogeneity by age, because it may not be that like nobody is like all the same, but just older versus younger. So it, it's probably like that there are subgroups of, women ages such and such to such and such with this sort of clinical profile who may do better here versus another, multidimensional subgroup. And so the upshot is that there's identification of subgroups with heterogeneous treatment effects, very well could involve the intersection of a whole bunch of characteristics, if that's what's meaningful, biologically. Okay, so our goal was to learn a rule to assign treatment with either injection naltrexone or buprenorphine to individuals to reduce the risk of relapse to OUD. And so this is also called an intent to treat average treatment effect. And then after we do that, we're going to estimate the extent to which risk of relapse could be reduced if we would have applied the rule to assign all these participants in this trial to medication type. And we're going to compare it to several things. So first, if the treatments were randomly assigned, which of course they were in the trial, so that's the same as just the observed risk of relapse. If everyone had been treated with injection naltrexone, or if everyone had been treated with buprenorphine. And so we're going to use, as I think I said before, optimal individualized treatment rules. These are rules that, when applied, maximize treatment success across the population, or you can also do it so that you're minimizing, a negative outcome, an undesired outcome. And they can be simple. They can be, treat everybody with buprenorphine. That's a treatment rule if that maximizes success. Or treat homeless individuals with injection naltrexone, stably housed with buprenorphine. But they could be significantly more complicated. And that's what we kind of want to allow for, thinking back before about people being multidimensional. It could be, it could be that they are more complicated. So the data for this, again, we're using this randomized trial, and it's actually pretty big for an OUD trial. It was 570 participants. We have a whole bunch of covariates, which I'm not going to go over here, but I'm listing them that we're considering as effect modifiers. And so that's, again, the thing that we care about if we want to, if we're trying to optimize treatment outcomes. And in this trial, participants were followed for 24 weeks. And this is, I think, pretty common because with opioid use disorder, it's not like you get a medication and you're acutely, you're better short term and you can just discontinue it. A lot of people, need to take medication for months, years, and sometimes their whole life. So the first thing that we have to do is define the individualized optimal treatment rule. And so I'm doing that here. It's denoted with a D and then V. And so V is just saying it's a function of some subset of our observed covariates that are effect modifiers. And so that's what the V is. And then this is also just putting it in terms of counterfactual notation, where we have Y and then this little subscript A is the counterfactual outcome when treatment is set to some value little a. And so A equals 1 here represents injection naltrexone, A equals 0 represents buprenorphine. And so this is, and so if you just look at like the very center, I don't know if you can see like my little cursor hand moving over it, but if you look at the very center, okay, it's saying this, you know, we're looking at, well, what would the counterfactual outcome be had the individual been prescribed injection naltrexone versus buprenorphine? And it's taking, again, these covariate values in here, V. And so it could be, so this is also called the complier average treatment effect, this expectation of the average treatment effect conditional on covariates. V is the conditional average treatment effector that Kate. And so, and then this one outside is just an indicator function. So if it's saying, well, for, you know, some subgroup characterized by little v, if their risk of relapse on naltrexone, this Y sub 1, is less than what it would be on buprenorphine, Y sub 0, so that would be, this indicator would be yes, then you would treat them with naltrexone, because that would mean that they would have the lowest risk of relapse on naltrexone. Whereas if their Y sub 0 is greater than their Y sub 1, you know, again, like for those who have this little v, then you would treat them with buprenorphine, because then you would be minimizing their risk of relapse. So that's all. When you see these, this is commonly how these individualized rules are notated, but that's all it means. It's just like very intuitive. Whichever one is going to give the best outcome for a subgroup is the treatment that you pick. And so what we did, now we have to estimate this quantity, right? And so we did this using the efficient influence function of the average treatment effect, regressed on covariates, and that's estimating this part. A nice thing about this is that it's doubly robust. And we actually did, I wrote that we did 2 approaches for this because that's what I'm going to show, but we actually did 3. So we did adaptive lasso. And so what that's doing is that it's pruning down the set of covariates down to those that are, you know, that we think are really the true modifiers of the average treatment effect. And then we did an even more regularized version where we just, it's a simple single variable algorithms where we're just saying, okay, we're going to take the one baseline covariate, that's the strongest effect modifier, and we're going to use that. We also did a third one where we did a really flexible library of machine learning algorithms called SuperLearner. And it's an ensemble approach, and that's super flexible. So that's like on the other end of the spectrum, but we did all 3 of these. And I'm going to show you results for these 2, and you'll see like these 2 perform really similarly, and actually so did the SuperLearner. And we also used tenfold cross-fitting for all of these approaches. Okay, so that's the work that we have to do in estimating the rule. Now that we have the rule, we can say, okay, what's the estimate? Let's estimate what would the risk of relapse had been if we had implemented that treatment rule. And so this is what this part here is, this expectation of Y. This D star I'm saying is the treatment rule that we estimated with adaptive lasso. And then this D prime is the treatment rule that we estimated with the single variable algorithm. And I am a big fan. I mean, I feel like I learn from people's code like almost exclusively. So I am a big fan of posting whatever I do online. So all the code to replicate what we did is posted. Okay, and then here are results. And so we'll look at the left side first. So to orient you, the y-axis is the expected risk of relapse by 6 months. And you can see here, like these risks of relapse are really high, right? And so the first part is randomized assignment. So that's what happened in the trial. And then next would be, well, if we had given everybody buprenorphine, what would the risk of relapse be? You see, it looks a little bit lower than randomized assignment. The third one is what if we had given everyone naltrexone? That looks a little higher. And then the last two are our rules that we estimated. So this first one with the smaller confidence intervals, that's the adaptive lasso method. And then the next one with the wider confidence intervals is the single variable algorithm. But you can see that they look pretty close to each other, but they also are performing a little bit better than everything else. And so the next step, of course, is to see, well, are they actually performing better than everything else? And so the graph on the right is the expected difference in the risks of relapse by 6 months. And so again, we have, so this is comparing Lasso, which is the circles, and single variable, which is the triangles, to randomized assignment, buprenorphine only, naltrexone only. So first, compared to randomized assignment, these rules do perform better. So had we implemented them, we would have reduced the risk of relapse. As compared to what actually happened, they also look like they're better as opposed to giving everybody buprenorphine, but slightly less so. And then they are also better than giving everybody injection naltrexone. Okay, so what did we do? We learned this individualized treatment rule, we applied it, and the one that we estimated using adaptive lasso would have reduced the risk of relapse by 12%, which translates to a number needed to treat of 14. And then the single variable rule, I didn't tell you what the single variable was, but it was homeless status. And that performed actually really similarly. So it reduced risk of relapse by 14%. And homeless status also makes intuitive sense. So buprenorphine, people usually come in, they get a prescription, and then they have to keep track of their medication and take it every single day. Come back in, get another prescription, keep track of it, take it every single day. Well, you can imagine that if somebody doesn't have stable housing, then that could actually be pretty difficult to do. Whereas injection naltrexone is a monthly injection. They come in, they get an injection, they don't have to worry about keeping track of medication. And the other cool thing about learning this single variable rule and then comparing it and seeing actually it performs really well is that it means that this would be actually a really simple adjustment to clinical practice. And so, let's say a provider just asks their patients, do you have stable housing or don't you? And then they use that to decide if patients were presenting in an office such that they would be given either an injection, naltrexone, or buprenorphine, just asking that question could meaningfully reduce opioid use disorder relapse rates. And we then did another analysis, which isn't published yet, kind of doing the same idea of learning an optimal rule, but choosing among the 3 medications for opioid use disorder. So choosing among buprenorphine, methadone, and naltrexone. These are the same graphs that you saw before, like the same orientation where this left side is expected risk of relapse. Here, though, we're only looking at 12 weeks, not 24 weeks. And that's because in order to do this, we had to actually combine 3 trials together. But we have, we're still looking at the adaptive lasso, which I'm putting my cursor over here. And then we're also looking at super learner. And you can see again, like these perform pretty similarly. And then when we look at the expected differences in risks of relapse by 12 weeks, we see that as compared to buprenorphine, actually, the rules that we learned here perform pretty similarly, I think, to just had everybody been given buprenorphine, but they seem to perform better than giving everybody methadone or giving everybody naltrexone. For this, so in terms of our updated, these like new results, we talked about this interpretable rule, or the rule that we learned using Lasso performs similarly to the super learner rule, which is also a black box rule. And we found that we could reduce risk of relapse by 21% or 29% as compared to giving everybody methadone or everybody naltrexone. But the risk reduction compared to buprenorphine was not very much. It was just 8%. And for the interpretable rule that we learned with this, we sadly didn't have homeless status because we didn't have it for the other 2 trials that we needed to combine here. So we couldn't look at that. But in terms of what we did have, we found that level of discomfort with previous withdrawals was important. Having cocaine use disorder, recent IV drug use, benzodiazepine use, identifying as Hispanic or Latino, Latina, and having epilepsy were all pretty important in determining which treatment would be optimal for somebody. So I said before, sadly, we couldn't incorporate homeless status across this. And then I will just mention this. I won't go into it because it's a detail, but it's one that I'm actually really interested in, because I think a lot of times we combine data from multiple trials, or if you think about, when studies are conducted across multiple sites, we combine that data all the time. But whenever we do that, we're actually required to have some transportability or data fusion assumptions with that. And I think a lot of times folks don't test those. So anyway, for this, that means that we have to assume a common outcome model conditional on covariates and a given treatment across trials, which we can write like this. Now we couldn't test this for all of the medications because we only had methadone in one trial, we only had naltrexone in another trial, but we could test it for buprenorphine, which we had across all 3 trials. So we would write it like this: if buprenorphine is our A equals 0. And we could actually test it. And so I'm including the link for the approach, which is this link number 9 here, but it's pretty nice. And so we found actually that there's evidence that this one trial called CTN27 was different than the other 2 trials. And so we actually didn't include it. We threw out the buprenorphine arm of that trial. And it made sense too, stopping to think about it, because in this trial, which was a comparison of buprenorphine and methadone, the administration of buprenorphine was changed to match that of methadone, which is different from how it is in the real world. So it kind of makes sense. Okay, so now I'm going to go into the second strategy, but I want to double check and see if anyone has any questions, anything they want to talk about. No.
Did you select the homeless status for the single variable, or was that identified?
Yeah, it was identified.
How did you identify it?
It was so what the algorithm did was it went through a screener, and so it went through that whole big list of all the covariates, which was a ton. It's like 40, and identified the one that was the most important effect modifier.
I see.
Yeah,
okay. So that wasn't an a priori thing. That was analytically driven. Okay.
Yeah, but it actually makes sense. And there was another paper that had also found it, but found it doing the way that Tyler Vandervelde wrote the paper that he didn't like. They had found it that way. And so it was kind of nice that we, could replicate that same finding.
Very nice.
Mm-hmm.
I have a follow-on question. I was a little surprised to see your super learner performing a little less well than the Lasso. Probably not a terrible difference, but
do you
have any thoughts on that?
We find this now I have found this 3 out of 3 times. So we found this here, we found it, I didn't show it, but in in the earlier paper where we were just doing between naltrexone or buprenorphine, we found it. I found it in another one where I was trying to optimize a mediated effect. I found it, and I'm not totally sure what's going on. Yeah. And we're doing a whole bunch of work, you could say you're probably overfitting, and we're doing a whole bunch of work to avoid that. It's not just the super learner is cross-fitted, the entire process is cross-fitted. So yeah, so I'm still pretty stumped about that, but it has been a consistent finding.
Does the Lasso include a few more I don't know a whole lot about the Lasso. Does it include a little bit of parametric smoothing that might be helping it out, or?
This is not traditionally, because you're not specifying a model for it. It's I called it Lasso, but it's this funny they called it the authors who developed it called it adaptive Lasso. It's still based on the efficient influence function. So
Yeah.
So no, it's not like I'm specifying a model for that either.
This is a sidebar, but very, I think it's kind of cool given the hype around the superlearner.
Yeah. So anyway, it's something that I want to dig into more. Like one thing that I kind of wonder about, well, yeah. And I feel like with, people are learning a lot more about these heterogeneous treatment effects and their stability or lack of stability. And, also learning about, not only their stability, but like when, like kind of what your sample needs to be in order to get these theoretical guarantees. And it turns out to, like, from my understanding, it needs to be actually really huge. And so it could be that we are so far from where we need to be to get these theoretical guarantees that theory is kind of breaking down. Like what we would expect based on theory is not actually happening.
Yeah, thanks for that reflection. That's really interesting.
Well, thanks for the question. Okay, so the next strategy that we looked at was the actual dosing strategies for two of these medications we talked about. With injection naltrexone, it's a monthly injection. So, kind of the decision making for the provider once they decide on a medication, which we tried to address with the first strategy, is how do you decide? But if they decide on injection naltrexone, they're kind of like, then their decision making is kind of done at that point. But for buprenorphine and methadone, they would still have to make this decision about, okay, well, what's the right dose? And how do we increase the dose? When do we increase the dose? Things like that. So that's what we're trying to address here. And likely those are both important factors for how effective the treatment is. But yeah, clinicians, from my read of the literature anyway, like I have not found a lot of quantitative evidence-based guidance for, how to ramp up the dose and what to ramp it up to. And so it seems to be something that's really, clinician specific. So some tend to use low doses because of concerns for diversion or sedation, and they may respond to use by increasing the requirements for therapy. Others may respond to use by increasing dose and may be more likely, maybe more free with increasing dose, and tend to go higher. And there's evidence actually that higher doses may be needed. So in terms of buprenorphine, the higher doses more fully occupy the opioid receptors, and so it blocks the positive reinforcement of opioid use. There's evidence that higher doses reduce the risk of drug use and reduce the risk of overdose. And the current guidance, which I'm including a link to below, recommends a dose of at least 16 milligrams for buprenorphine. For methadone, higher dosages have been shown to provide better control of withdrawal symptoms in between doses, which is then thought to reduce the reinforcing effects of using opioids, which reduces opioid use. And again, the current guidance recommends having a minimum of 60 milligrams of methadone, but more typically this ranges between 80 and 120. However, what happens in practice seems to be, can be really different from what is recommended. So underdosing has been found to be common for both buprenorphine and methadone, and it's been implicated as contributing to suboptimal opioid overdose or opioid use disorder treatment outcomes. So for example, for methadone, just in 2017, someone found 40% of patients were still receiving doses under 80 milligrams, which is considered underdosing. And there's also evidence that this underdosing is racially patterned. So non-white patients are more likely to receive an optimal dose, which suggests to me anyway that this dosing and underdosing could contribute to racial disparities in retention and relapse. And so we were interested in how different dosing strategies that we hypothesized would be effective could lower the risk of dropout and relapse over the first 12 weeks of treatment. And it's an expansion of a previous question that we asked, which was, could dynamic dose increases, so continuing to raise dose in response to an individual's continued use, saturate more receptors and lower risk of dropout and relapse? So the question is, how can we answer this question? So here we're going to use something kind of related that's called dynamic treatment regimes. And that's where we use updated information on a participant's history or how they're doing in treatment to make informed decisions or modifications to their treatment in real time. Again, this isn't something else that I feel like is pretty widely used, but it hasn't been that widely used in the substance use world. And especially has not been used in terms of evaluating dynamic treatment for opioid use disorder. Okay, so we're going to estimate the difference in risk of relapse comparing 4 different treatment regimes. So one where dose is increased. So every week when a participant comes in for these trials, they have to say, well, they have to do this interview about like drugs that they used the previous, like each day of the previous week. And then they also submit a urine drug screen, which kind of captures drug use during the previous week. And so the provider knows, okay, is there evidence that the participant used opioids the previous week? And so the first treatment regime is saying, okay, increase the dose up until the maximum in response to our participants' opioid use. The second one is where dose is increased weekly, regardless of use, until some minimum threshold dose is reached. And then the third is a hybrid of those two. So where you would increase dose until a minimum threshold is reached and then increase in response to opioid use thereafter. And then the fourth one is holding dose constant actually after week 3 of treatment. And this fourth one may seem like, well, but who's actually going to do it? But actually that's like the most common one, basically. So we are able to compare these 3 other ones to holding dose constant. Okay, so for this this is similar to the update that I showed before. So we're using these same 3 randomized trials that are harmonized together. So that's over 1,800 people who initiated treatment with buprenorphine or methadone. And we're using, again, a lot of baseline covariates. And then we have 2 time variant covariates that we're using. So most recent dose, and then this weekly illicit opioid use that I kind of talked through. That's this combination of participant report, but also urine drug screen. And then here participants were followed for 12 weeks, just as I showed before. And so again, the main thing that we're doing here is well, 2 things. The first is that we're contrasting these relapse-free survival curves. So survival meaning that you haven't relapsed yet, of participants under each of the 3 dose increase strategies, D1, D2, D3 versus the constant dose strategy, D4. So this is what, if you were to write what I just said in notation, you would write it like this. And so we're just looking at weeks 4 through 12 for the outcome. And again, this is the counterfactual notation for the outcome, where Y sub D is the counterfactual risk of relapse in this hypothetical world where your dose would have been increased according to, D1, D2, D3. And then we're contrasting that with D4. The other thing that we did is we wondered, okay, well, is the hybrid strategy any better than either of its components? So the hybrid strategy is increasing dose up to a minimum, and then when you get to that minimum, increase in response to use. And so that's D3, and we're going to compare that to D1, which is increase in response to use. We're going to also compare it to D2, which is increase to a minimum. And then we're going to do these contrasts both in terms of the average treatment effect, which is what I showed here, but also the relative risk. And so to estimate this, we used a longitudinal, it's called a longitudinal sequentially doubly robust estimator. It's nice because it's actually doubly robust at each time point. So like at any given time point, if you estimate the treatment mechanism correctly or the outcome mechanism correctly, you should get a consistent estimate. It's efficient. And then we incorporated an ensemble of machine learning algorithms here. And then again, all the code to do this is at this site. So So I guess the first thing I wanted to talk through is, do people actually have, like, do we observe enough people with these at each week to actually make these estimates? And so these are people who were observed to have an increase, actually truly did have an increase under this hybrid strategy. For example, at weeks 3 through 11 for buprenorphine and for methadone. And so we see, like, some of these numbers, they do get kind of small in these later weeks. So that's just to keep in your mind as we go through. But then this is the constant dose strategy. And, keeping a constant dose is really, I would say, if you read the clinical guidance, is not really what is being suggested, but it was really common. And so these are how many people actually had the constant dose strategy at every week. So you can see there's a lot. And then these like D1, D2, D3, it's how many people who had the constant dose strategy actually would have gotten an increase under these alternative strategies. And so the upshot here is that actually a lot of the participants in these trials received the constant dose strategy, but they would have received dose increases under these other strategies. So between 64 and 90%, depending on the week, would have received increases in their dose had other strategies been followed. Okay, so here's looking at the results. If we look at the top one first, this is the risk of relapse, again, by 12 weeks. And so these do look like, I guess, kind of like survival curves. You're just accumulating risk of relapse over time. And you can see that the constant dose strategy D4, is clear. You can eyeball it and you can see, okay, that's the worst. And then you would say second comes this increase to a minimum threshold, which looks better than keeping dose constant, but it doesn't look as good as either increasing dose in response to use or the hybrid strategy. And then the average treatment effects are shown below with their 95% confidence intervals. And those just kind of confirm what you can eyeball on the top, which is that, any of these dose increase strategies are better than keeping dose constant, but increasing dose in response to use or the hybrid strategy are best here for buprenorphine. And then here are the results for methadone. So we see like generally the same thing in terms of, keeping dose constant is worse, does the worst, but you can see that really any of the strategies that increase dose, they look pretty much similar to me, eyeballing it, and they all look better than keeping dose constant. And you can see, that's kind of confirmed down below with the average treatment effect. They're all better than keeping dose constant, although it gets a little bit murkier in these like mid-weeks of weeks 8 through 10. Okay, and then we asked the question, well, is doing the hybrid strategy better than either of its components? This was for buprenorphine, and so here the hybrid strategy is the reference. So when you see estimates that are positive, that's saying, okay, for example, for this increased dose to a threshold, this D2 strategy, it's significantly worse than the hybrid. But this D1 strategy of increasing dose in response to use is pretty comparable to the hybrid over time. We did the same for methadone. Methadone doesn't really make a difference. All three of these strategies performed pretty similarly. So I kind of talked through a lot of this, but for buprenorphine, we found that the hybrid strategy would reduce risk of relapse by week 12 by 24%, which is a number needed to treat of 8. For methadone, the hybrid strategy would reduce it by 12% for a number needed to treat of 14. And this pretty much this corroborated our earlier study that showed that doing this increase in dose in response to use works really well for buprenorphine and would significantly reduce risk of relapse. And so together, I think these two studies have provided some evidence actually quantifying the effects of these dosing strategies. So instead of people having to say, well, it tends to, in my experience, this has worked better, or I think this should work better, we can actually put some numbers to it. And overall, I tried to provide 2 examples of using dynamic treatment regimes or individualized optimal treatment rules. Those I think are both cornerstones of precision medicine. And I think are important for understanding when and how we can tailor treatments to particular individuals to be responsive to, you know, who walks in the door, but then also how their health and their behavior and clinical characteristics change over time. So a huge thanks again for having me. This is a delight. So I'm putting up my funding for this work and then collaborators, which it has been really fun to work with these folks, a lot of whom are psychiatrists at the New York Psychiatric Institute.